This lesson is about acid-base imbalances, specifically metabolic acidosis versus metabolic alkalosis. Before we talk about the pathophysiology of metabolic acidosis versus metabolic alkalosis, it's important to remember that this is happening behind the scenes in your patient. This is never going to be the diagnosis they have upon admission. Let's talk about normal arterial blood gases first. Some lab values you will need to remember for your NCLEX, and this is going to be one of them. A normal pH will be 7.35 to 7.45. Now, if you'd like to remember CO2, all you're going to do is drop that 7, 35 to 45. And finally, bicarb, just think 2 plus 2 plus 2 is 6, or 22 to 26. Whenever we're talking about metabolic acid-base imbalances, we're always talking about the kidneys. And so with metabolic acidosis, we're talking about the kidneys being too acidic. So we're thinking closer to that 22 range. This is because you have too much acid on board, such as hydrogen, or a loss of base, which is your bicarbonate. Metabolic alkalosis is going to be when your bicarb is closer to 26, or that alkalosis side. This is from too much base bicarbonate, or you're losing too much acid. Now, if you have trouble remembering that pH, just remember my little picture on the right, acidosis, that D equals your pH drops. So your pH is going to be low with metabolic acidosis versus alkalosis, see that K, your pH, it's going to kick up. So your pH is going to be high with alkalosis. Let's talk about the etiology of metabolic acidosis. So this is when your bicarb would be low from your kidneys. Now your bicarb is going to be low from what? An increase in acid. So we're thinking that there's too much acid production. Maybe your patient's in lactic acidosis from sepsis or carbon monoxide poisoning. Think about DKA, diabetic ketoacidosis, from putting off ketones. Or maybe your patient ingested too much acid. Think of aspirin, better known as acetylsalicylic acid, or ethylene glycol, which happens to be antifreeze poisoning. Your patient can also have an increase of acid because they're not excreting acid. So think of kidney disease, acute kidney injury, chronic kidney disease, or if your patient happens to be for dialysis. Now, rather than an increase in acid, again, we can be losing base. So think of diarrhea, and my memory trick for this one is metabolic acidosis. I'm pointing to my butt. Now let's talk about the etiology of metabolic alkalosis. So this is when our kidneys have a lot of base. Now this can be from large amounts of GI loss, so I'm thinking I vomited. Your patient has NG tube dissuctioning, and they're losing hydrochloric acid out of their stomach, causing them to become more base. Your patients can also ingest base, which is basically just antacids. They're actually ingesting bicarbonate. The other thing that we can do to accidentally put our patient in metabolic alkalosis is medication. Anytime we give our patients medications like a diuretic, thiazides, we're actually excreting a ton of urine. And hydrogen is in urine, which is an acid. So this would make our patients more base. Let's talk about the clinical features between metabolic acidosis versus metabolic alkalosis. So your patient in metabolic acidosis, meaning more on the acid side, you're going to see signs of hyperkalemia. This is because potassium and H+ have an affinity for each other. So as you have more acid in the blood, you will have more potassium in the blood as well. This is why ECG monitoring is so important, and your most tested ECG change is going to be tall, tented T waves, which is a sign of hyperkalemia and a change in ventricular depolarization. You can also see Kussmaul's respirations, so you're thinking fast, deep breathing. Your patient is trying to blow off that acid to compensate. And for metabolic acidosis, don't forget my memory trick, metabolic acidosis. We're going to see diarrhea in these patients. In metabolic alkalosis, we're not going to see a ton of symptoms, just your patient feeling generally unwell. But remember, the symptoms are always related to underlying causes, so maybe your patient has been vomiting, and my memory trick for that is metabolic alkalosis. Think of vomiting for this one. Let's talk about the compensation between the kidneys and the lungs, because these are our two main players when it comes to acid-base balance. Metabolic acidosis, we have a low pH, and remember, our bicarb is more on that acidic side, so it's going to be low. What do the lungs do? They're going to respond by breathing quicker. As our respirators go up per minute, we are actually blowing off CO2, which is an acid. This is how our blood becomes more base. Now, eventually, we'll start to compensate, and that bicarb will come up, and hopefully our pH will follow. Let's talk about metabolic alkalosis and compare. Now we have a pH that is high, and also we have a bicarb or HCO3 that's high. Now our lungs are going to compensate in the complete opposite. Now your patient's going to be breathing slower, they're going to hold on to CO2, which is an acid, and that's how our blood becomes more acid. Eventually that bicarb will drop, and our pH will eventually follow. Let's talk about the nursing interventions between metabolic acidosis versus metabolic alkalosis. So with either of these conditions, we know that our healthcare provider is going to help us diagnose the problem. Remember, acid-base imbalance is happening in the background. It's never the main diagnosis. But what do nurses do? For acidosis, we definitely need to monitor labs, especially serum lactic acid if our patient happens to be septic. Now we need to replace those fluids and replace electrolytes. Medications, if my patient is metabolic acidosis, I have to treat that diarrhea. Now, if we don't catch these, eventually you may have to push sodium bicarb IV. Let's talk about metabolic alkalosis. Again, healthcare provider treating that underlying condition, but now we're replacing those fluid and electrolytes. Let's talk about medications. We want to avoid diuretics. Now, this is because we want our patient to stop urinating. We're going to hold on to hydrogen when we're holding on to urine, becoming more acidic. We're going to give antiemetics because remember metabolic alkalosis. Our patient's probably vomiting, and we want to avoid suctioning because we want to keep that hydrochloric acid in the guts, helping our patient return to acid-base balance. So just to summarize metabolic acidosis, we need to remember with acidosis, our pH drops down. So we're looking for a low pH less than 7.35. Now this is because we have too much hydrogen, which is an acid, and we have a low bicarbonate. So our lungs are going to try to compensate, and they're going to do that by breathing faster, pushing out that CO2 to become more alkalytic. When the pH returns to normal, this is when our patients are fully compensated. Finally, let's summarize metabolic alkalosis. Now remember, with alkalosis, our pH does what? Kicks up. It's going to be over 7.45. Now this is because we have low hydrogen, which is our acid, and high bicarbonate, which is our base. Our lungs are going to try to compensate by breathing slow. We're going to retain CO2, which is an acid, bringing our body back to acid-base balance. Now remember, we won't be fully compensated until our pH is between that normal 7.35 and 7.45.